Hi everyone, this is a grand rounds presentation which I had a interesting case in the clinical rotations. Start. So this is a 58 years old female patient with a past medical history of hypothyroidism, AFib with RVR, type 2 diabetes, essential hypertension, Bell's palsy, and benign pancreatic mass. She doesn't have any surgical histories, no family history as well. She was a never non-smoker, non-drinker, and never used drugs. We didn't discuss about the sexual history with the visit, but patient has a husband and one child. The chief complaint was patient said I feel a bit weak and I'm worrying about swelling on my face and neck. So with including old cards, patient is a 58-year-old female came to the clinic for her follow-up visit after she came back from the Philippines. Patient was admitted in the hospital last December 25th due to hyperthyroidism or thyroid toxicosis and AFib with RVR. During the visit, she found she has a pancreatic mass and she was advised to go back to Philippines and to have MRI and ERCP to continue the treatment. During the discharge from the Saipan, she was given a methimazole 10 mg POBID, but the provider in the Philippines changed to a 20 mg in the morning and 10 mg in the evening, and she's been complying with the new changes. So fortunately, the pancreatic mass was found benign and she came back from Philippines on April 2026. Since then, patient reported a gradual onset of symptoms like she noticed some swellings on her face and eyes. She was also feel that her neck is getting swollen with generalized body weakness. Patient said that she was running out of propranolol for a week, so she didn't take it, and she denies any fever, diarrhea, nausea, or vomiting. For the ROS, so she was with generalized weakness, but denies fever or chills or weight loss. She denies any headache or injuries, but with facial swellings and periorbital edema bilaterally. She was also positive for enlarged right thyroid. She denies sore throat, rhinorrhea, or congestions. She also denies chest pain, palpitations, orthopnea, or peripheral edema. No shortness of breath, dyspnea on exertions as well. She denies abdominal pain, nausea, vomiting, constipation, or diarrhea, or hematochezia. She also denies any difficulty in urinating or blood in the urine. She also denies any joint pain or swellings, but with positive enlarged thyroid, especially on the right neck side. But she denies any heat intolerance, unexplained weight loss, or excessive sweating. So on the physical exams with the vital signs, she was elevated. She was with a slightly elevated blood pressure, but she also has a history of hypertension, and her heart rate was on 71, which was not an AFib RVR that she had on December 2025. The thing that we can check is that her weight when she was admitted in the hospital, she was 41.8 kilogram. This was probably due to a hypothyroidism. And the recent weight we check on her current visit, it was 61.6 kilogram. So basically, she gained about 20 kilogram on past 5 months. So this is a female adult, alert oriented times 4 and cooperative. She wasn't in a distress, but she looks fatigued in appearance. For the hint, so no trauma, no scars, no any tenderness on the head, but with bilateral periorbital edema noted. Parla with extraocular movements were intact, no conjunctival discharge, external urethral symmetry with no redness or swellings. Tympanic membrane was clear, no signs of infections. Nasal passage also clears, no congestions. Mucous membranes were also moist and no ulcers, and her tonsils were not enlarged. The only thing that was enlarged was her thyroid on the right, on the next side here. For the cardiovascular, she was having a normal heartbeat, S1, S2, regulars, no murmurs, gallops, or any extra heart sounds. No chest pain. Peripheral pulses are very palpable, and she with capillary refill less than 2 seconds. No any peripheral swellings or signs of bleeding. For respiratory, her Breathing was good. It's like unique. No any using of accessory muscles. No tenderness. Not in distress. Her breathing sound was clear. For the GI, her abdomen was round, soft, and non-tender to touch. Bowel sounds are heard in all four quadrants. No any guarding signs, rebound tenderness. No any enlarged livers or signs of ascites also noted. For muscular, no any acute joint or muscle pain, no swellings, and no decreased range of motions. Although she was fatigued, but her strength was 5 out of 5. Still, we found enlargement of thyroid gland on the right side. For our diagnosis, so based on the given presentation symptoms and her history of changes of methimazole, so we come up with the methimazole-induced hypothyroidism. So methimazole is a medication that treats hypothyroidism, which prevents thyroid gland from producing an excessive amount of thyroid hormone. So patient has been on total of 30 milligram of methimazole for the past 5 months without any following laboratory studies. And she present today with such symptoms that typically how hypothyroidism patients manifest, like periorbital edema, facial swellings, weakness, fatigue, and enlarged thyroid gland. Another differential diagnosis, or just the diagnosis that we found was very interesting, is that it was a Brugada syndrome. So, given the history of AFib with RVR and her thyroid status, we ordered EKG and this one came out. So, according to the study, it says that if the patient has a severe hypothyroidism, whether caused by medicine or not, it can mask or come up with Brugada syndrome type 3, but this is not really a diagnostic one. So, which means that Brugada syndrome is a inherited disorder that actually can cause a cardiac sudden death or ventricular fibrillation. But this manifestation is just a temporary electronical changes because of the thyroid level in the body. So it says that once we fix the thyroid hormones, then it will be just normalized or fixed by itself. But this one was truly interesting. Another differential diagnosis could be acute heart failure. Patient present with the facial swellings, puffy eyes, with a generalized body weakness. These are the early signs of systemic fluid retention and fluid overload in the heart failure patients. So she's with the history of AFib RVR with the thyroid disorders and taking of antihypertensive medicines and anticoagulants. This could be actually potentially like causes some burden and then injuries on the heart, and could be early signs of acute heart failure in this visit. However, she denies any chest pain and she has no any cardiac issues at this time. So this diagnosis could be actually less likely happened. This is more on about drug-induced hypothyroidism at this time, but still we need to rule out. So diagnosis and plan of care. So we order some CBC, CMP, TSH, of course T3, T4, lipid, BMP, and A1C. We also order EKG and then we found Brugada. So the result was very interesting, but that's what we expected. So her TSH was 64.9025 micro-IU, which is actually like almost like 15 times higher than the normal reference. Of course, her T4 was 0.15 nanogram, which is way low than the normal, and the T3 as well is only a 0.66 picogram, which is way lower than the normal range. So which means that we can say, based on the patient's lab, we can confirm that she was profoundly a hypothyroid state. So we have to start with the care, or make a plan of care based on her diagnosis. So instead of adding any other medicines, we started with the pharmacological management of decrease the dosage of a methimazole. So we decreased the methimazole to 10 milligram POBID, and we discontinued the propranolol anyway. She's not on AFib with RBR, and she was not taking for a week, and she didn't complain of any symptoms at this time. So our preceptor said that she doesn't need it anymore. For the non-pharmacological management, we encourage her to take Mediterranean diet, which is rich in anti-inflammatory components like omega-3 fatty acids, antioxidants, and vitamin C and E. We also encourage her to continue with daily activities and low-intense exercise as tolerated, because based on the research, it says the long-term exercises like more than 8 weeks can actually help with the normalize of TSH level. For the patient education, so we educated patient what happened to her, how does methimazole, this medication can cause a hypothyroidism, and how this disease maker, how make this disease maker experience this kind of symptoms and like that. We also instruct the patient to hold the methimazole dose for the tonight and resume it by tomorrow with the new changes of dosage. She agreed. We also educated patient to just go visit the ER right away if she having a worsening of swellings, trouble breathing, that makes her trouble breathing. We also ask her to go when she has change of mental status or getting more lethargic. And we also ask her to come back in a week to see any changes or progressions about it. And after 1 week, then probably we're gonna have her to come back every month to check the TSH level as well. Thank you.